So today we talked about the treatment of obesity with obesity medications. And I think the first thing that's most important is that we buy in that obesity is a disease and that we treat it like all the other diseases that we treat, like type 2 diabetes, hypertension. So we put people on treatments, whether it's lifestyle, medication, surgery, and we need to keep them on therapy long term, or else the weight just comes right back. We all get frustrated. The patient gets frustrated, we get frustrated. So really we're thinking about long-term therapy. And we have many great options. We have some older generation medications that confer 5-10% weight loss, that are safe to use long-term and are associated with clinical benefits. And now we have newer drugs that give us 15, 20, now maybe even up to 25% weight loss, again, leading to significant clinical benefits, ultimately benefits on cardiovascular disease, sleep apnea, and other really important complications that improve and often go away with these treatments. Again, remembering that these treatments are a long-term treatment, and perhaps they take one medicine for a year or two to help them lose weight and maybe transition to something else down the road. But we don't have all the answers right now, but certainly we're getting there. We also talk a lot about cardiovascular disease. So what do people with diabetes and obesity die from? They die from cardiovascular disease. And that's been shown over and over again. And especially with diabetes, it's basically what we call a risk equivalent. If you have diabetes, it's the same thing if you have had a heart attack in terms of your risk for another heart attack. And the longer you have diabetes, the greater the risk for having cardiovascular disease. So we're talking heart attacks, strokes, and peripheral arterial disease, but also heart failure is another big one. So the guidance is to really treat all the cardiovascular disease risk factors. So yes, it's treating the diabetes and using the appropriate drugs that have cardiovascular benefit if possible. But it's treating lipids aggressively, and specifically we want to treat the LDL down to target and to goal. We want to treat blood pressure aggressively, and there's it's a moving targets there, but currently we still want to try to get patients below 130/80, often requiring more than one medicine, 2 to 3 medicines to do that. We want to consider aspirin therapy or antiplatelet therapy for the right patient, definitely for secondary prevention, but consider in the highest risk patients in primary prevention as well. And then we want to screen for heart failure. We want to screen for peripheral arterial disease, which is often missed until patients have significant symptoms. And then obviously treat those patients aggressively. Yeah, one of my favorite parts of this conference is reviewing and going through different cases with the other speakers. You know, we can go bounce back and forth on what our thoughts are, because there's no one right way to do these things. So we present cases that are cases that we would see every day in the clinic and go through, you know, how would we what's the process? What are our goals for treating that patient? What are the treatment options? Why this option versus another for this specific patient? And we'll go through that, with different perspectives from the different speakers.
Perfect. Thank you very much.